Welcome to Quick MCAT Lessons, where I try to explain MCAT topics in 10 minutes or less. Today, we're continuing our discussion on the renal system, and we talked about how the filtrate goes from Bowman's space to the proximal convoluted tubule, and now we're going to talk about where it goes from here, which is the loop of Henle. So the loop of Henle dips into the medulla and is divided into descending and ascending limbs. Now it's important to know that the medulla is also divided into the outer medulla, which is closer to the cortex, and the inner medulla. In normal conditions, the osmolarity of the cortex is the same as that of the blood. However, deeper in the medulla, the osmolarity of the interstitium, which is the space surrounding the nephron, can range from isotonic with blood, which would be the case when trying to excrete water, to 4 times as concentrated, and this would be in efforts to conserve water. So water moves out of the tubule into the interstitium, and eventually back in the blood. But if the concentration is the same in the tubule and interstitium, this would mean there are no gradients, and water will be lost in the urine, which is why an isotonic interstitium leads to excretion of water, and a concentrated or hypertonic interstitium leads to reabsorption. Now getting back to the loop of Henle, so the descending limb is permeable to water, but not to solutes. So water is reabsorbed into the hyperosmotic medullary, and this concentrates the filtrate. The ascending limb, in contrast, is impermeable to water, but it actively transports sodium, potassium, and chloride out of the filtrate, diluting it. The loop of Henle and the vasa recta create the countercurrent multiplier system. This is done to ensure that the flow of filtrate through the loop of Henle is in the opposite direction to the flow of blood through the vasa recta. Now remember that the vasa recta is a mesh of capillaries that surround the loop of Henle. If the two flowed in the same direction, then they would quickly reach equilibrium and the kidney would be unable to reabsorb as much water. But by making the two flow in opposite directions, the filtrate is constantly being exposed to hypertonic blood, and this allows for maximum water reabsorption. Remember that a hypertonic solution is more concentrated, and due to osmosis, water goes toward that, leading to maximum reabsorption. At the transition from the inner to outer medulla, the loop of Henle becomes thicker in an area. This is called the diluting segment. The thickness of it is not due to the cell's lumen enlarging. Rather, it's actually due to the cells becoming larger. And they are larger because they contain a lot of mitochondria, which is needed for reabsorption of sodium and chloride by active transport. Furthermore, since so much salt is reabsorbed while water is stuck in the nephron, the filtrate becomes hypotonic compared to the interstitium. This is the only segment of the nephron that can provide urine that is more diluted than the blood. This is important in times of overhydration and provides a mechanism for eliminating excess water. Overall, at the beginning of the loop of Henle, the filtrate is isotonic to the interstitium. This leads to a slight degree of dilution from the beginning to the end of the loop of Henle. The volume of water also decreases majorly by the end. This shows a net reabsorption of a lot of water. After it's out of the loop of Henle, the filtrate moves into the distal convoluted tubule, which is the DCT. The DCT is also in the cortex and it fine-tunes the electrolyte balance. It is also responsive to hormones like aldosterone, which increases sodium and water reabsorption. This further concentrates the urine. Just like in the proximal convoluted tubule, the distal convoluted tubule also secretes waste products, like the proximal convoluted tubule. Now when the filtrate reaches the collecting duct, it passes through the medulla toward the renal pelvis. The concentration of urine is majorly dependent on the permeability of the collecting duct, and it is highly sensitive to antidiuretic hormone and aldosterone. As permeability of the collecting duct increases, so does water reabsorption, making the urine more concentrated. The reabsorbed water enters the interstitium and it goes to the vasa recta, where it re-enters the bloodstream. When the body is well hydrated, the collecting duct will be fairly impermeable, which leads to a decrease in concentration of urine. When dehydrated, ADH and aldosterone act to increase reabsorption of water, which leads to the more concentrated urine. The collecting duct is the point of no return. There will be no further reabsorption past this point. From the collecting duct, urine collects in the renal pelvis and is composed mainly of urea, uric acid, and excess ions like sodium, potassium, magnesium, and calcium. It then flows down the ureter to the bladder. The bladder is a muscular sac that temporarily stores urine. It's lined with transitional epithelium surrounded by the detrusor muscle. This contracts during urination. Control of urination, or micturition, involves both an internal urethral sphincter, which is involuntary and made of smooth muscle, and an external urethral sphincter, which is voluntary and made of skeletal muscles. Now when the bladder fills, stretch receptors trigger reflexes via the spinal cord and brainstem, allowing voluntary control over urination. In a normal state, the internal urethral sphincter is contracted, but when the stretch signals come, then the detrusor muscle contracts. The contraction leads to relaxation of the internal urethral sphincter. This reflex is called the micturition reflex. The person can then relax the external sphincter to urinate or keep the external sphincter contracted, which will cause some discomfort, but the pain goes away after a little bit, and the internal sphincter contracts once again. However, if the bladder is not emptied, this process will start over again. So just to finish up, let's quickly talk about the kidney's role in regulating blood pressure. The kidneys play a central role in regulating blood pressure, primarily through the renin-angiotensin-aldosterone system, and through the actions of vasopressin, or ADH. When blood pressure or sodium levels falls, the juxtaglomerular cells of the kidneys release renin. This reacts to the formation of angiotensin II. Angiotensin II causes vasoconstriction and stimulates the adrenal cortex to release aldosterone, which would promote sodium and water reabsorption in the distal nephron, and it would also increase blood volume and pressure. Aldosterone also causes an upregulation in potassium excretion, which leads to lower potassium levels. Vasopressin, or antidiuretic hormone, released from the posterior pituitary in response to high plasma osmolarity or low blood volume, increases water permeability of the collecting duct, concentrating urine and conserving water to support blood pressure. Osmotic and oncotic pressures influence how fluids move between blood vessels and nephron tubules. Osmotic pressure refers to the pull exerted by solutes in solution, like sodium, while oncotic pressure is specifically the osmotic pull from plasma proteins, mainly albumin. In the nephron, water follows solutes during reabsorption, so high blood osmolarity, which means more solutes in plasma, encourages water reabsorption. Conversely, low plasma protein levels reduce oncotic pressure, potentially leading to decreased reabsorption and more water loss in urine. The kidneys also help maintain the acid-base balance via the bicarbonate buffer system. When blood pH drops, which is acidosis, the kidneys increase hydrogen secretion and bicarbonate reabsorption. This raises pH. During alkalosis, bicarbonate may be excreted. These renal adjustments are slower than respiratory compensation, but essential for long-term pH regulation. That's it for today. Next time we'll talk about the skin.